Welcome to today's Explainer. We're going to step into the role of a medical detective right now. Inside our bodies, there's literally a constant stream of clues flowing through our veins, telling us exactly how our organs are functioning, or, in some cases, failing. Today, we're decoding one of the most critical biochemical mysteries in clinical medicine, the disorders of acid-base homeostasis.
Think about this for a second. Every single moment, your cells are producing acid, just as a byproduct of keeping you alive. So, how does the body stop your blood from becoming a deadly acid? It's an incredibly high-stakes, around-the-clock battle. If the pH of your blood tips too far in either direction, cellular function just grinds to a halt. Today, we're going to look at exactly how our biology walks this tightrope and what happens when it loses its balance. Here's the map for our investigation today. We've got 5 main stops. First, the acid-base balancing act. Then, unpacking metabolic acidosis, understanding metabolic alkalosis, respiratory acid-base disorders, and finally, mixed disorders and a quick summary. All right, Section 1, the acid-base balancing act. Before we can spot the criminals, we need to lay down the fundamental biological laws of the land. Okay, the Henderson-Hasselbalch equation, I know, it sounds super intimidating, right? But honestly, it's just a set of biological scales. Your blood's pH is determined by a simple ratio. On the top of the fraction, you have bicarbonate, which acts as a base. On the bottom, you've got carbon dioxide acting as an acid. To maintain a normal pH, these two components have to perfectly balance each other out. So how does the body actually control that fraction? Well, it's the ultimate showdown, lungs versus kidneys. Our kidneys handle the metabolic side, controlling the bicarbonate. When they make changes to fix an imbalance, it takes time, but those long-term fixes are usually complete. Our lungs, on the other hand, pull the respiratory lever, controlling the carbon dioxide. They can change our breathing rate instantly for short-term fixes, but that compensation is often partial and incomplete. Moving right along to Section 2, unpacking metabolic acidosis. This is where we track down the culprits behind the most common acid-base disorder you're going to encounter.
So, metabolic acidosis kicks in when any process abnormally lowers your plasma bicarbonate. But hey, as medical detectives, just knowing it's low isn't enough. We need the why. Enter the anion gap. This is a brilliant little tool that looks at the difference between our positively charged ions, mostly sodium and potassium, and our negatively charged ions, chloride and bicarb. In a healthy person, this normal gap sits right around 15 to 20 millimoles per liter.
And this gap? It's our primary fork in the road for diagnosis. If the gap is wide, meaning we've got unmeasured rogue acids floating around like lactic acid or toxins, we call that HAGMA, high anion gap metabolic acidosis. But if the gap is perfectly normal and bicarbonate is still dropping, that's NAGMA, normal anion gap metabolic acidosis.
Let's put this into a step-by-step game plan. Step 1, you check electrolytes to confirm that bicarbonate is indeed low. Step 2, calculate that anion gap to choose your path, HAGMA or NAGMA. Step 3, check serum potassium, urea, and creatinine to see how the kidneys are holding up. And finally, Step 4, you run specific tests like ketones for diabetics or lactate for patients in shock to nail down the exact toxin or failing organ. Okay, let's look at the HAGMA suspects. These are the heavy hitters. We're talking lactic acidosis, which spikes when tissues are starved of oxygen from things like hypoxia or sepsis. Diabetic ketoacidosis, a really severe diabetes complication. Kidney injuries where daily acid waste just builds up. And of course, toxins, things like ethanol, salicylate overdoses, or methanol poisoning that literally dump foreign acid directly into the bloodstream. Nasty stuff. Contrast that with our normal gap culprits, NAGMA. Here, the body is usually just losing massive amounts of bicarbonate directly. The biggest offender by far? Severe diarrheal disease. We also see it with excessive saline infusions in the hospital, or this fascinating complex kidney defect called renal tubular acidosis, where the kidney tubules specifically fail to secrete acid or reabsorb bicarbonate properly. And, when we talk about something like renal tubular acidosis, it's really easy to get lost in the chemistry. But we aren't just looking at abstract numbers on a page. In pediatric patients, this severe acid imbalance shows up as recurrent vomiting, chronic diarrhea, and an inability to grow properly, what we call failure to thrive. It's a stark reminder that cracking these chemical mysteries is absolutely crucial for relieving severe human distress. All right, shifting gears to the opposite end of the spectrum. Section 3, understanding metabolic alkalosis. Let's look at the processes that abnormally increase plasma bicarbonate. Just like we use the anion gap for acidosis,
Alkalosis has its own specific detective tool, the urinary chloride test. It neatly splits metabolic alkalosis into two treatment camps. If urinary chloride is low, under 20 millimoles per liter, it's saline responsive. That usually means the body is losing chloride and fluid, maybe from severe vomiting or cystic fibrosis. If it's over 20, it's saline unresponsive, pointing to deeper issues like diuretic use or hormone imbalance like Cushing's syndrome.
Now, the pathophysiology here is actually wild. When blood gets too basic, plasma proteins start aggressively hoarding free calcium. So a patient's total body calcium might look totally normal, but their free ionized calcium absolutely tanks. This triggers some crazy neurological and physical symptoms. We're talking facial twitching, brutal headaches, and those severe hand and foot cramps known as carpopedal spasms. We've talked a lot about the kidneys and metabolism so far. Now it's time to check on the lungs. Section 4, Respiratory Acid-Based Disorders. So the lungs control the acid side using carbon dioxide, and our brain's reaction to this is super fascinating. In respiratory acidosis, PCO2 is abnormally high. This hypercapnia actually makes the blood vessels in your brain dilate, causing throbbing headaches, stupor, and even coma. But in respiratory alkalosis, where PCO2 is dangerously low, it completely flips. It constricts the brain's vessels, triggering nausea, dizziness, and dangerous cardiac arrhythmias. So what actually causes respiratory acidosis? Basically, anything that stops you from effectively breathing out. It could be an airway obstruction from asthma or COPD. Maybe the brain's command to breathe is blocked by an opioid overdose or head injury. Or it could be mechanical, like a spinal cord injury or myasthenia gravis, where the breathing muscles literally just can't do the work, trapping toxic acid inside the blood. And respiratory alkalosis is the exact flip side. You're breathing way too fast, blowing off all your CO2. Often, this is psychogenic, triggered by extreme anxiety or a panic attack. But it could also be your body desperately trying to get oxygen at high altitudes or battling a pulmonary disease like a pulmonary embolism. In cases of pure anxiety, this is exactly why having someone rebreathe their own CO2 into a simple paper bag can literally cure the disorder right on the spot. All right, we've mapped out the 4 primary disorders. Let's enter the final, most complex phase of our investigation. Section 5, Mixed Disorders and Summary. This right here is the ultimate test for any medical detective. A mixed acid-base disorder is when you've got more than one primary abnormality happening in the exact same patient at the exact same time. The normal rules of biological compensation, yeah, they totally go out the window, completely obscured by multiple culprits attacking the body at once. To really grasp how dangerous this is, let's look at 2 extremes. Imagine a patient in cardiopulmonary arrest. Their lungs aren't clearing CO2, and their tissues are starved of oxygen, dumping lactic acid. You get respiratory and metabolic acidosis compounding together, crashing the pH to deadly lows. On the flip side, what if a patient has pneumonia, making them hyperventilate, while also suffering from severe vomiting that drains their stomach acid? You get compounding respiratory and metabolic alkalosis, pushing blood pH to life-threatening highs.
Okay, here's your ultimate cheat sheet. This synthesizes every single pattern we've mapped out today. Just by tracking the direction of the arrows, whether pH, PCO2, and bicarbonate are moving up or down, and how potassium is shifting, you can rapidly trace the path right back to the root disorder. This core logic is exactly what you need to confidently decode complex blood gas results.
As we wrap up this explainer, I want to leave you with a thought to ponder. The body is endlessly resilient, constantly pulling biological levers to keep us alive. But if our kidneys and lungs constantly act as an internal medical detective team, covering for each other's failures, how often are they perfectly hiding a complex mixed disorder we haven't even noticed yet? Keep your eyes sharp, trust the chemistry, and keep practicing those investigative skills. Thanks for joining me on this deep dive.